Okay. And the methods to record this intraoral tracing is by using a graphic methods or using a zinc oxide eugenol impression plaster or impression compound can be used. Also, orthocal can be used. Just more 15 minutes to go. The topic is going to get completed. Occlusion. Theories of occlusion are going to be conical, bone wheel theory, and spherical theory. According to bone wheel theory, that is teeth move in relation to each other as guided by condylar and incisal guidances. It is also called as theory of equilateral triangle, according to which there is a 4-inch distance. That is like distance from the one condyle to another condyle is about 4 inch, and from condyle to the central incisor is going to be 4-inch distance. That is what is called equilateral triangle. Whereas conical theory, it was proposed by Hall, and it proposed that lower teeth move over the surface of upper teeth just as in the cone, generating an angle of 45 degrees, with the central axis of the cone tipped at the 45-degree angle to the occlusal plane. Spherical theory is proposed by Monson and proposed that lower teeth move over the surface of the upper teeth as a surface of sphere with 8 inches, and the center of the sphere is located at the glabella region. That is at the center of our base of our nose. Or that actually we say the glabella is at the pointed point where all the sutures meet up. And the types of complete denture occlusion are the balanced occlusion, monoplane occlusion, lingualized occlusion, and neutrocentric occlusion are present. And the Tillman's formula for that balanced occlusion is going to be condylar guidances, crossing that is into incisal guidance by compensating curves and occlusal planes, and also the incisal curve relations, which are the one which is going to have, and that is condylar inclination, which are the one going to dictate all these factors. And balanced occlusion is a simultaneous contacting of maxillary and mandibular teeth on the right and the left in the anterior and posterior relation in centric and eccentric. That is like whenever patient performs any movement, all the teeth should come in contact. And that is established by following these 5 principles. That is condylar guidances, incisal guidances, compensating curves, condylar inclination, and the our this occlusal pattern of the teeth. That is occlusal design, how the teeth are present. And coming to the requirements of working occlusal units, they should be efficient in cutting and grinding, decrease buccolingual width, they should be reduce buccolingual width, or they should be placed on the ridge of the crest and surface to receive and transmit the forces, and also workload near the anterior posterior center. And plane of occlusion as parallel as possible should be present. And the requirements of the balanced occlusal units are they should contact the second molars when we incising. That is like whenever we incise, our posterior teeth will not contact in natural dentition. Whereas in complete denture, to have a balanced occlusion, it should be having like a contact at the second molar region, and they should have smooth gliding movements. They should not be sudden movements. And during lateral excursion movements, the balancing contact occurs. See, this is one of very important thing. You can take a screenshot. Buccal incline of upper lingual cusp and lingual incline of the lower buccal cusp are going to contact, and they are called as medial or non-working inclines. And working side contact occurs at the lingual inclines of the upper buccal cusp and buccal incline of the, that is like whenever we move the teeth, suppose like we are moving the mandible to the right side, then the buccal incline, you can see the buccal incline of these mandibular teeth. Suppose it is being moved into this side. So the buccal incline of the our mandibular teeth will be contacting the lingual inclines of the buccal teeth. So over here, the much more clear diagram can be like, suppose like this is a maxillary and this is a mandible one. Okay. So the buccal incline of the mandibular one and the lingual incline of the maxillary buccal cusp will be contacting, and this is called as balancing side in contact or working side contacts, and vice versa in the balancing side or non-working side. Coming to the lingualized occlusion, it was proposed by Geisy and Payne. According to this theory, that is like a maxillary lingual cusp are the main function and occlusion elements. And this type of occlusion involves the use of large parietal cusp against a wide lower central fossa. See, this is one of the when we follow and monoplane or non-balanced occlusion. It includes the concept of spherical theory and organic occlusion. Uh, Occlusal balancing ramps for the protrusive balance is used to set the non-anatomic teeth. And whereas the monoplane occlusion, sorry, neurocentric occlusion was given by D1, and this concept is similar to the monoplane occlusion teeth. They are used to set the non-anatomic teeth, and according to this concept, the plane of occlusion to be flat and parallel to the residual alveolar ridge. And term neurocentric denotes an occlusion that eliminates the anterior posterior and buccolingual inclines in order to direct the forces to the posterior teeth. Coming to the compensating curves, there's monsoon's curve, curve of P, anti-monsoon curve, curve of Wilson. Very, very important thing. That is like definitely one curve will be definitely asked. Monsoon curve is a curve across the palatal and buccal cusp of the maxillary molars. And only if the teeth are set following this monsoon curve, we will get a balanced occlusion in the lateral movements. And the anti-monsoon curve or curve of Wilson is the opposite to the direction of the monsoon's curve. Premolars are arranged according to this curve and it is convex upwards. And curve of speed is a very well versed curve, right? Comes from the lower canine to the buccal cusp of the posterior teeth and through the head of the condyle and lateral curves non-transversally from one side of the arch to other. Pleasure curve, it was given by Max Pleasure. It is convex upwards except in the last molar region. It runs from the lingual cusp of the second premolar to the distal buccal cusp of the second molar. This curve runs from the parallel cusp of the first premolar to the distal buccal cusp of the second molar in the maxillary region. Coming to phonetics, C. It is also one of the very important thing. Labial sounds, these are BPM. That is like whenever we pronounce this, we are going to have a bilabial contact. BPM, or also called a papa babama. And labiodental sounds are F, V, which are made between the upper incisors and labiolingual center to the posterior third of the lower lip. And the placement of the maxillary anterior teeth in complete edge is too far. That is like if we place it too superiorly, sorry, and anteriorly also might result in a difficulty in pronouncing the F and V. If upper anterior teeth, this is one of the very, very tricky question also they ask you. If upper anterior teeth are too short, F sound will be pronouncing like a V. Whereas if at all they are too long, then F will pronounce like a V. Vice versa is what that means if at all they are long, instead of F, it is going to be V sound. If at all is short, V sound also will pronounce like an F. And the alveolar sounds, that is like T, D, N, S, J, which are made within a valve formed by the contact of the tip of the tongue with an anterior part of the hard palate. Okay, and if the teeth are too far lingually, the T will sound as a D. So this is why in childhood also we've been learning this Papa Bama, this right, Kaka Gaga, everything. The sequence is because those age area where we will try to pronunciate the sounds, thereby our tongue will be twisting according to it. So thereby our pronunciation will be enhanced in the future period of time. Similarly, if at all we do not follow in the complete dentures, it is going to be flop of the dentures. Sibilants, that is S, Z, Ch, J, are called as sibilants, which are also called as alveolar sounds, and the upper and lower incisors should approach to each other but should not touch. If the gap is very narrow, it results in a that's like a wheezing kind of sound, and if the gap is broad, it results in a tisping sound. That is like if the gap is narrow, wheezing like that it will be present. If the gap is broad, it is like tisping, tuck, 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 like this. It will be present. Dental sounds are going to be like th, in which our tip of the tongue will be contacting the upper and lower anterior teeth. And palatal sounds ear, sh, j, the ear, sh, sha kind of thing, where the velar sounds kg, ng, and vowels have no effect on the dentures. And velar sounds like kg, ng are used to check further like how whether the patient is having any effect or not. Coming to teeth selection, the maxillary anterior teeth occlusion rim should be parallel to the interpupillar line, and the mandibular one should be along with the our lower incisor edge. position. That is like C. When we set the mandibular teeth, it should be 0.5 mm above our lower lip level. And for the maxilla, it should be parallel to the interpupillar line, and also it should be 1 to 2 mm visibility from the when the patient is in the relaxed state. By very important measurements, that is anthropometric measurements. Bizygomatic width by 16 is going to give the width of upper central incisor, whereas bizygomatic width by 3.3 is going to be width of upper anterior teeth. Cranial circumferences by 10 is going to give the width of upper anterior incisor teeth. You can see in the complete dentures. And Williams classification of facial forms, very important thing, that is a square, tapering, ovoid, and combination. One, dentogeny concept is given by Fresh and Fisher. It is proposed that a teeth selection should be done based on the concept of age, sex, and personality of the patient. That is like for the female patients, it should have a round angles and point angles should be rounded. Whereas for the male patient, it should be a sharpened one. And quality of the color of the anterior teeth, that is like hue, saturation, chroma, value, and translucence. Very important thing. That is like you can take a screenshot. Definitely, one question will be from this topic, without which there is no Prostho paper at all. Who is going to the specific wavelength of the light, and saturation of chroma is going to be color per unit area, whereas value is going to be lightness or darkness of an object, and translucence is the one going to be an object to be partially allow the passage of the light. Coming to maxillofacial defects, that is like I am going to cover the MFP in brief, which can be very frequently asked for you. That is like maxillofacial defects are of intraoral, extraoral, and combined. Intraorally, it can be maxilla can be affected or mandible can be affected. And extraoral, it can be ear, nose, eyes, and also our like orbital regions can also be affected. And combined regions are going to be, there is like maxilla combined with the orbital. That is like maxilla orbital defects are going to be. And in maxillary, it is going to be congenital and acquired. That is congenital is going to be cleft lip and palate very frequently that we see. And acquired is the one that is trauma, surgery, or pathology that is acquired in the later period of time. Coming to the Armani classification, very important classification. That is like in the class 1, that is till the midline but not crossing the midline. Whereas class 2, that is like unilaterally present, it does not does not come to the midline also. Whereas in the class 3, center of the palate is affected. Class 4 is going to cross the midline. And the class 5 is going to be posterior palate is affected. Class 6 is anterior palate is affected. And the classification of edentulous ridges are in the FPD I'm coming part. That is like class 1, class 2, class 3, and class 2 are present. More, I guess, only 15 slides were present. Class 1 is the loss of facial-lingual width and normal apicocoronal height. Class 2 is going to be normal facial-lingual width and loss of apicocoronal height is present. Very important classification. Class 3 is going to be, it is a loss of both height and apicocoronal. This is important thing. Hibbert's classification is present. And coming to the components of the complete denture, there are 3 parts, that is retainer, pontics, and connectors. And function of the parts are retainer is going to support the abutment teeth, pont is going to replace the missing teeth, connectors are going to be pontics to the retainers. Very frequently they ask that questions. They are going to be what are the parts of a FPD or what are not the parts of FPD. Like that they can ask you. And one of the very important things that is like, see, there's a difference between the clinical crown and exact crown, the length of the clinical what we study is that is like in the first year. That is clinical crown length is the one what we see in the patient's mouth, or the length of the crown when we see in the patient's mouth. Whereas exact crown length is going to be from the cemento enamel junction to the cusp tip or incisal edge. It is going to call as anatomical crown length. And roots with a greater labiolingual width than mesodistal width is going to have a round root, and long irregular shaped divergent roots offer good support. and short conical blunted pore support going to be present from these short conical roots. In the crown root ratio, the ideal is going to be 1:2, optimum is 2:3, and minimum is about 1:1. Periodal ligament or root surface area, Johnson et al. Proposed the Andis law. The total pericymental area of the abutment teeth should be equal to or greater than the combined pericymental area of the teeth to be replaced. Teeth with greater pericymental area is seen in the maxillary first molar, that is 433 millimeters square. In the mandible, it is about second molar, that is 431 millimeters square. That is the mandibular first molar is the second in position. That is first position is going to be maxillary first molar. Second position is going to be for the mandibular first molar. And teeth with less pericymental area is the mandibular central incisor, which is 154 millimeters square. Cantilever abutments are the abutments means only one end they have been supporting and the other end they have been free. That is like where one end is being supported and other end is completely free. Cantilever bridge, what we see. Selection is critical and also it withstands a much more amount of see, it has to withstand both the pontic and also the abutment loads. So it is going to be very critical and ideal replacement is a canine going to replace the our lateral incisor. Suppose 1 2 or 2 2 is missing. Then with the help of 1 3 or 2 3, we can replace the missing lateral incisor. And the abutment tooth should have a good support also. Contraindications are endodontically treated teeth, teeth with short reeds, steep bite, and steep palatal vault. Fire abutments, that means fire abutments is one of the very important for the seesaw appearance is seen. That is like very frequently they ask in the exam where here the load will act and here the dislodgement will be occurring. Because the abutment on either side there is adventitious places. And one teeth missing, one teeth missing. Over which we have been fabricated FPD singly. Suppose if we fabricate like this completely, then it is going to dislodge from here whenever the force is being applied over here. In that condition, we do an tenon martis or key way. That is like where the key is placed and a key way is placed. So this is shock absorption is going to occur. So thereby the forces will not be transmitted to the other side of the abutments. This is one of the very important things that they will definitely going to ask. It is one difficult one. That is like tilted molar or cantilever or this tenon martis. Tilted abutments are going to be most commonly used in the mandible third molar. And the main problem that we encounter is a single path of insertion we cannot encounter, cannot establish. To overcome the problem, the mesial reduction of the third molar is done and modify the partial veneer crown with a 3/4 crowns or orthodontic treatment movement can be done or non-rigid connector can be used and telescopic crown can be used. That is like we can place a crown which acts as a paralleling to the our suppose like in the mandible region 3 8 is present and 3 7 is missing. Then the 3 6 and 3 8 will be made parallel by the help of telescopic crown. Extensively damaged abutments are that is like in RCT conditions. See, whenever most of like in the clinical practice, what we see is like they do the RCT followed by they give a crown, but actually this should not be done. In that condition, we should go with a placement of the post and co. According to the textbook I am speaking, every RC treated tooth should be replaced with the help of a post and core only. And grooves are going to be, see, if the crown structure is very less, then we have to go with the help of grooves. That is like buccal retentive grooves can be added. It should be about 1 millimeter wide and pins are added in the inadequate axial height. Two types are present, that is parallel pins and non-parallel pins. Box forms are it is used in the cases where proximal lesion interferes with the placement of the retentive groove and it increases both retention and resistance. And restoration of endodontical retentive teeth, double core that is present, post and core, very, very, very important thing that is like our like after obturation that is done, the post should extend up to two-thirds of the crown, and one-third should be left over because that acts as a apical seal. Okay, one-third should be left over, BP cones, and remaining two-thirds should be with the help of our post, followed by core should be present. And they can be done with the see orifice opening is done with the GG drills, and then with the help of piso reamers we can remove the our gutta percha. Retainer is a part of FPD which unites the abutment with the remaining of the restoration, which can be extracoronal or intracoronal retainers. And the extracoronal retainers are going to be complete veneer crowns or partial veneer crowns or conservative crowns. Complete veneer crowns are complete metal crown, complete porcelain, metal ceramic or gold crowns. Partial veneer 7/8, 3/4, or 1/2 crowns and laminates very frequently. It is one of the very game changing also. Laminates one and resin bonded ridges. Intracoronal retainers are the one which is going to obtain the retention resistance from the from and also have an intimate contact of the restoration within the confines of the coronal portion of the tooth, and it includes inlays, onlays, and pin ledges. Coming to gingival surface of the pontic, that is like in order to maintain a healthy nature of the underlying tissue, pontic should have a passive contact. That is like, see, here the abutment is present, here the abutment is present, and here the missing teeth is present. So we should have a smooth contact in this gingival surface of the pontic. Otherwise, our ridge is going to get ulcerated and damaged. And should not be any blanching when we place in a pontic, and it should have a minimal tissue contact and should have a concave buccolingually and convex mesodistally. They can ask you like what are the features which should be present in a pontic. Like that, they can ask you, or in vice versa. That is, what are the features which should not be present in the pontic. Like that, also they can ask you. But it is one of the very important things because 90% of the cases are going to be our FPD only. And highly glazed porcelain is material of choice because once we glaze, all the roughened surface will be smoothened. So thereby no microbial attachment will going to occur. Based on the type of material, it is like a metal ceramic pontics. It is going to indication for the posterior teeth and advantage of aesthetics and strength. And contraindication is the long span ridges are present. Okay, all metal pontics are indications of bruxism, posterior teeth, and children's, where contraindications are the anterior teeth, and advantages are the strength is very high, and they are indicated in the bruxism patient. Absolutely. In bruxers, we should indicate to the all metal pontics only. And resin veneered are the one where the indications are the temporary crowns, advantages are single step and easy procedure, less time required, disadvantages are less strength and less abrasion strength are present, and contraindication is that they are not a definitive restorations. They are indicated when a child is growing. Suppose if a child is of about 14 years and he has got a fracture, then we will be indicating resin veneered crowns. Once the patient reaches the adult age, then we will be replacing within a permanent crowns. That is either metal ceramic, all metal, or all ceramic crowns. And all ceramic crowns is going to be very high, expensive also, and very money earning also for you all. And the advantage is going to be eye aesthetics, eye strength, and disadvantage is attrition of the opposite teeth occurs. But still, the people want this only because they want like zirconium, and they say that like we want good in aesthetics, good in aesthetics, but they don't know that with the help of this zirconium crowns, your teeth is going to upgrade. Also, they don't care about it. They want aesthetics. That's it. With the shifting lifestyle has been occurred in the recent days. And coming to based on mucosal contact, one question will definitely be present. Saddle pontic, ridge lap pontic. Saddle pontic is the one which has a contact only on the buccal or the palatal side, and concave gingival surface is present and it's less hygienic and is difficult to maintain. Whereas ridge lap is the one which is going to resemble the natural teeth and adapts to close to reach, less hygienic and more aesthetic is seen and often causes inflammation of the gingiva. Modified ridge lap pontic are the design the way the relatively less tissue contact is present only on the buccal side, both hygienic and aesthetic is seen. It has T-shaped contact is seen, and when ridge lap is reduced further, this known as lap facing is going to occur. And a conical, it is used where definitive that's defective or incomplete yield sockets. That is like it is going to be somewhat like this, where we place like this in the socket. And the spheroidal pontic, it has only contact in the ridge crest region only. There's only one pinpoint contact is going to occur. And solitary pontic, very, very important pontic. And this is what we generally indicate for the posterior regions. That is like, suppose this is a ridge and the teeth will be, but pontic will be like this only. There's a gap between the pontic and the gingival surface. Very good in hygiene, but aesthetic wise, it is very poor. In that condition, so that's why when the aesthetic is considered, then we will be going with a modified ridge lap. Okay, this modified ridge lap pontic is the one that we indicate for the uh, aesthetic suspension. This is in the anterior region. This is the posterior region. We can indicate anyone, but definitely the sanitary pontic is the one that is going to be better. Types of there is resin bonded reteners, very, very important thing. That is like there are three types: Rochet, Maryland, and Virginia bridges. Rochet is the first designed resin bonded bridges. It has wings that is like the pontic, and either side there's a wings. We have fabricated it, and it's like a very tedious procedure. Also, I can say like the wings are present, and there's a conical perforations for the retention to be achieved. And Maryland bridges are is involved from the Rochette bridge. It is evolved from the Rochette bridge, and it has a micro porosities which have been developed from the etching of the tissue surface of the that is like the crown is present, and then we will be etching it. So thereby we get a rough surface area. But it is also poor in stability support. Thereafter, the Virginia bridges has been came into light. These bridges uses a particular roughness or retainers, and they are fabricated by using a resin with a salt sprinkle on the surface of the resin pattern. And this is called as lost salt technique or mechanical retention. Very, very important thing. The conical parts are present in the rochet, and etchant is used in the Maryland bridge, and lost salt technique is employed in the Virginia bridges, where there is a much more roughened area on it, according for the mechanical retention. Coming to the connectors, the portion of the fixed partial tensor that unites the retainers and pontics. Type of connectors are rigid connectors and non-rigid connectors. Non-rigid are the tenon mortis, loop, split pontics, or cross pin and wing type of connectors that are present. Loop pontics are the one that is like in the anterior region, we will be indicating it. Suppose we don't want to display it, then we will be indicating a loop connector on the lingual or palatal side. And thereby the midline diastema is to be maintained. Sometimes patient asks them to maintain the naturality. So in that condition, we can ask for going for the loop connectors. And loop is present on the lingual aspect of the process, so thereby good in aesthetics. And biomechanical that is principles, that is like, see, the biomechanical principles are going to be actually, see, according to Nalaswamy and Rangarajan, in Rangarajan and Nalaswamy leave apart, if at all we go within Rosen still, we have a biological, mechanical, and aesthetic principles we need to follow. And whenever we prepare the teeth, we need to follow certain rules and regulations. That is taper. Taper should be, these are comes under the mechanical ones. That is like taper should be, if at all taper is more, the retention is going to be poor. And less taper should be present. That is like on either side, it should have an only 3 degrees or 6 degrees maximum. And convergence should be 6 to 12 degrees. That is like on this side 3 degrees, and this side 3 degrees. Then you're going to get a 6 degrees of convergence. If at all it is 6 degrees on each side, then it's going to be 12 degrees. Till the 12 degrees, it is acceptable. Beyond that, it is not acceptable. Length is going to be, with increase in the length, the retention is going to be increase. And substitution of the internal features, that is like if the crown height is less, then definitely we need to go with a proximal grooves, and this is what we have done in the my FMR patient. That is like she's not willing for the post and co. So what I did is like placement of the buccal retentive grooves I placed. So thereby the retention I got, and till now she has a very good utilization, and she has no problems. Indication is over taper preparations or less crown height, and prepare that partial veneer crowns are present. And path of insertion is an imaginary line along which the restoration can be placed onto the remove or can be removed from the preparation. Coming to structural durability, very, very important thing, that is like, see, the ability of the material to withstand is depending upon the thickness of the material that is present. And for the metal ceramic, it should be 1.5 to 2 mm on the functional cusp. That is C. In the maxilla, the buccal, that is parietal cusp are functional. Whereas in the mandible, the buccal cusp are functional one. So this functional cusp should be reduced or should be given a bevel to accommodate it. Whereas non-functional cusp, it is about 1 to 1.5, and gold alloys 1.5 on the functional cusp and 1 mm on the non-functional cusp. And metal with a porcelain veneered, it is about 2 mm with the functional and 1 to 1.5 in the non-functional cusp. And all ceramic, it is about 2.0 mm of all the cusp. And functional cusp bevel is going to be done on the parietal cusp of the maxilla and buccal cusp of the mandible, which are called as functional cusp of the maxilla and mandible by simultaneously. And poor adaptation is seen in the if at all the crown has no adaptation to the ridge tooth, then it's going to cause a marginal leakage. Secondary care is pain and food accumulation. There are two types of margins that are present: supragingival margin and subgingival margin. Most of the patients, what we do is like, see, people are nowadays are doing only subgingival margins, even for the posterior teeth. But actually, I see that they should not be done. At least equigingival or supragingival should be done, no matter what. Because like supragingival margins are above the gingival margin and they are healthy in tooth. And advantage side is going to be easy to maintain and easy to take impressions also. They're also easy to evaluate in the future purposes. But if the patient is going to subgingival margins, very frequently, even the prosthodontist, what I see also, like works of the like many previous patients who are got done at some other places, they do have a subgingival margins even in the posterior regions. So thereby what happens is the gum tissues will swell, thereby resulting in a complete, even the swelling in that region, that the gum has swollen and it has covered entire tooth also. Up to the, I will just draw it. Suppose this is a tooth, then the gums have been swelled to till this level. Till this level, the gums have been swollen. So that's why we have to go with the supra or equigingival only. Indications are short clinical crown, anterior teeth, and teeth affected by subgingival or cervical caries, and additional retention is required. Disadvantages are going to be difficult to maintain. It's the one big disadvantage from it. That's why we don't utilize it. Uh, Coming to occlusal rest for the RPD, the rest are important points. That is like occlusal rest are prepared on the occlusal surface of the posterior teeth, and they should be about off the buccolingual width and 1/3 to the off of the mesodistal width. And reduction of the marginal ridge of approximately 1.5 mm. No sharp angles or line angles should be present, and floor of the rest sheet should be parallel or it should be plane, so that all the forces will be transferred to the underlying tooth. Coming to the lingual rest, it is used primarily on the maxillary canines with a minimum tooth preparation, and it is a V or half moon shaped, made by 1/4 inch burr, and it is also called as cingulum rest. Mesodistal length is about 2.5 to 3 mm. Buccolingual is about 2 mm, and depth is going to be 1.5 mm. Incisal rest is going to be less desirable in the anterior teeth. Indications on the mandibular canines and position near the distal incisal angles of the abutment teeth. On the incisor may be used for the stabilization also. Extensions are going to be width about 2.5 mm and depth about 1.5 mm. Till the with this we have completed it. Does anyone have any doubt? Anyone has any doubt? See, if at all you want a detailed explanation, I just covered superficially. That is like covering all the very, very frequently asked and very, very important points. Okay. So you don't need to worry if at all, if you have any further, like you want to be in detail to be explained, you can go to the website and see each and every topic specific videos where you can see see. It is about like if at all I take and explain all and each and every topic in detail, it is going to take at least 2 to 3 weeks, right? So, in order to cover all the very important points and very frequently asked questions, I covered it. Even if you have any doubt, you can ask. Everyone, no one has any doubt. So, can we close the session? Just drop a thumbs up in the chat. Then I will close the session. Uh, no one has any doubts. Okay, with this, I am closing the session. Thank you. This is Dr. Vikram signing off. Always try to remember the clinical perspective of the subject, then only learn. See, how you're going to get interest is because when you know the value of the subject, then you only get interest regarding the subject and will remember the terms. Okay? Take care.